This topic will be covering in the three part. First part, I'll be discussing the anatomy of the shoulder joint. This will be the similar in almost in all our subsequent modules as well. So first, the anatomy. I'll be demonstrating anatomy with the help of a software. After that, Dr. Series will be showing or demonstrating, or not demonstration, basically discussing about the clinical aspects. What are the different types of shoulder pain causes, and some of the ultrasound slides as well. And after that, I'll be showing the demonstrations on the volunteers. And while I'll be demonstrating on the volunteers, I'll be also showing you the needle trajectory, that how, if you are trying to do the procedures, how you are going to hold the probe and in which directions your needle will be coming and how to inject. That part also I'll be discussing at the end. So this is today's schedule, and without any delay, let us start. So Series, my slides are visible?
Yes, sir.
Okay, thank you very much.
Yes.
So this is your shoulder. So shoulder joint is basically a complex joint. So what are the joints there? So basically there are three true joint and one is your pseudo joint. So true joints are, one is this is the biggest joint. This is your glenohumeral joint. Then second joint, true joint, is your acromioclavicular joint. These are the two common areas where from the pathologies are there which might be causing different types of pain. And another true joint is here. It is your sternoclavicular joint. So, but there is a pseudo joint as well. So what is that pseudo joint? So pseudo joint is this is your scapula. This is your scapula, and this is your thoracic cage. So this forms a pseudo joint, scapulothoracic joint. So that is also a joint, and all these four joints together is your shoulder joint. So first, let us see the bony part, and then we'll be looking at the ligamentous part, and then some of the bursas, which are common causes of pain. And at the end, I'll be showing the different muscles and the tendons, which is very important. So to understand the shoulder anatomy, the very, very important part is to understand the anatomy very nicely. So first is glenohumeral joint, because that is the largest amongst all these four joints. And here, the joint is formed by, one is this humeral head. So this is the humeral head, and this is your glenoid. So glenoid is a very shallow, and that is the reason why there is a labrum which elevates and gives the shape of a cup. So ball and socket joint. So this is the one joint, and here few things other to remember that. Sorry, let me. Okay, so here the head of the humerus, this is again the two important areas in the ultrasound. Very frequently we're talking about it. This is your greater tubercle, this is your lesser, greater, and this is your lesser. And there is a groove through which the long head of the biceps goes, and long head of the biceps becomes intracapsular, and there it goes like this and get attached at the superior part of the labrum. So this is your course of the long head of the biceps. We'll be showing that later on. So here the greater and the lesser tubercle. So muscles sort of be getting attached there. We'll be discussing the lesser tubercle gets the attachment of the subscapularis muscles. Subscapularis muscles comes like this and gets attached with the lesser tubercle. And in the this greater tubercle, there are three facets. So in that three facets, so there are three important muscles that is getting attached there. And I'm trying to erase the drawings. Then I'll be going to the other part. Okay. So if you're looking for the posteriorly, very important structure is your this is your spine of the scapula. And this spine of the scapula is converted into the acromion. So this is your acromion process. And this is the spine of the scapula. So the spine of the scapula is, whole of this, if you are looking about this whole of this, the scapula, posterior aspect, the spine of the scapula is dividing it into the supraspinatus fossa, infraspinatus fossa. So the supraspinatus muscle takes origins from here and goes below the acromion and comes here, getting attached to the superior facet. And infraspinatus muscles getting attached from the infraspinatus fossa, they are getting attached to the middle facet. And the pterispinal will be getting attached from here and will be getting attached into the inferior facet. So these are in the greater tubercle, these are the three different muscles which will be getting attached at the different part of the greater tubercle. And if you are looking from the anteriorly, anteriorly, I forgot to mention another very important part. What is that? That is your coracoid process. So if I'm again looking back here, so this was your coracoid process. So this is your coracoid process. So coracoid process is also very important because some of the ligaments like coracoacromial ligament is attached here, there. Also coracoacromial ligament will be coming from here. It will be getting attached here. Coracoacromial ligament. Then your coracohumeral ligament. I'm not talking about coracoacromial ligament will be coming here. Coracoacromial ligament also I'll be showing you. Coracoacromial ligament is also very important because that is making the tunnel through which the supraspinatus muscles comes. So coracohumeral ligament. Apart from that, the other ligaments which will be going coracoclavicular ligament. Coracoclavicular ligament will be again having the two part. One is the conoid part, another is trapezoid part. And few muscles are also getting originated. One of them is your short head of the biceps muscles, biceps muscles, and then is your coracobrachialis muscle. They are the two muscles. And from this side and from here, another muscles will be coming in the coracoid. Tip of the coracoid is the pectoralis minor. Let us clear this drawing. So anteriorly, these are the few things. One is your bicipital groove, another is your greater and lesser tubercle, and the coracoid process. Now we'll be looking the shoulder joint from above. So if you are looking shoulder joint from above, so this is your acromioclavicular joint. This is your acromioclavicular joint. I am still looking at the shoulder joint from above. So this was your acromial process. So this is the spine of the scapula which is getting converted. So this is your acromioclavicular joint is also a very important source of the pain. So acromioclavicular joint also we have to understand, we have to look under the ultrasound also to see the pathology and also to see the dynamic scanning to see if there is any subluxation or not. So with this bony anatomy, now let us see some of the connective tissues. Some of the ligament I have already shown you, but let us show some of the connective tissues. First, what came here? Let me magnify a little bit. So what came here was your synovial membrane. So first layer after the bone which is covering is your synovial membrane. So you know that the glenohumeral joint is a synovial joint. And after that, there are three important ligaments. This is your glenohumeral ligament. So this is your superior glenohumeral ligament. This is your middle glenohumeral ligament. And this is your inferior glenohumeral ligament. Inferior glenohumeral ligament, nowadays people are telling that the coracohumeral ligament thickness measurement is not that consistent to identify the frozen shoulder. Rather than more important is you're looking for the inferior glenohumeral ligament thickness. That is going more consistent. But again, ultrasound findings for this is not always supportive, but still that is one of the areas that we can do. So this was your the ligaments. Then basically these three ligaments are the thickened part of the joint capsule. So next is your joint capsule. So this is the joint capsule.
And just above the joint capsule, another very important ligament, what I have already shown you, that is your coracohumeral ligament. Coracohumeral ligament is starting from the coracoid and coming here, getting attached. Is basically bifurcates and getting attached both at the greater and the lesser tubercle. And if I am adding other ligaments, I have already shown you this ligament. So this was your acromioclavicular, coracoacromial ligament. Starting from the coracoid, it is going to the acromion process. And two other part of the ligament also I mentioned there. It is coracoclavicular ligament. So this part was your trapezoid part of the coracoacromial ligament, and this part was the conoid part of the acromioclavicular ligament. So there are two parts of this coracoclavicular ligament. So this was coracoclavicular ligament, this and this trapezoid and the conoid, and this was the coracoacromial ligament. All this ligament can be seen very nicely, and one vessels goes, like this. We'll be showing that, they will like this. One vessel will go. So now let us see the bursa. So there are the different bursas there. So this bursa, again, one of the very common bursa is the subdeltoid, subacromial. Sometimes some literature says that the subdeltoid and subacromial bursa is basically the continuous. So this was your subacromial, this was your subdeltoid. So maybe most of the times we call it together, subacromial, subdeltoid bursa. That is one of the very common area of the pain. This is little less common area. This is your coracobrachial bursa or subcoracoid bursa. There is another small bursa is there, just below the tendons of the infraspinatus muscle. This one, sorry, not taking color. Okay, so the bursa below the infraspinatus, and another on the top, that is subcutaneous acromial bursa. That is very superficial and sometimes very just close to the acromioclavicular joint. So these are some of the bursas which can be inflamed and which can cause the different types of pain. So I am now adding the muscles. So muscles are most important part of the muscles is the rotator cuff muscles. And just for the recapitulation, what are the rotator cuff muscles? The 4 rotator cuff muscles anteriorly. So just look at layer by layer. First, I am removing this front muscle, that is the pectoralis major. So the pectoralis major I am hiding. And then the 3 strips of the deltoid, anterior, I'm removing that. So whole of the deltoid went away. So anterior, middle, posterior part. And now we have exposed the rotator cuffs. So rotator cuff, let me, this was your long head and this was your short head. So I am removing the short head. Below the short head, we are having the coracobrachialis muscle. This was your coracobrachialis muscle. I'm hiding that also. So now what I am getting, let me remove that bursa also. So now what I am getting is this muscle is the subscapularis muscle. So subscapularis muscles, where it is getting originated. So I am removing the pectoralis minor muscles also. As I told you, 3 important muscles is getting originated. One is your pectoralis minor and 2 was coracobrachialis and the short head of the biceps. So I'm removing this muscle. So here, this muscle is your subscapularis muscles. So these subscapularis muscles getting originated from the anterior surface of the scapula and attached at the lesser tibia. So then let me remove this also, and let us see supraspinatus muscles. So this is your supraspinatus muscles. Supraspinatus muscles gets originated from the supraspinatus fossa above of the spine of the scapula, and it comes below this acromion, below the acromion, and get attached to the superior facet of the greater tubercle. So this was the greater tubercle. So this was the greater tubercle. So this was the superior facet, middle facet, and the inferior facet. So superior facet is where the superior facet is where, superior facet is where the supraspinatus muscles gets originated. So this was your supraspinatus muscle. And you can remember the function. The most important function is their abduction. So tendinous parts get attached in the superior facet of the graded tuber. And here we'll be discussing about the rotator cuff also. So rotator cuff is basically the interval. This is a gap. So one side we are having the supraspinatus tendon. Another side we are having this subscapularis tendon. And in between we'll be able to see the bicipital tendon. And above the bicipital tendon, we are having the coracohumeral ligament. And on the either side of this bicipital tendon, there is a gap. If you are going into that, you will be going into the intra-articular space. So to go into the intra-articular space within the joint capsule, either side of this bicipital tendon through the rotator cuff, this is called rotator cuff interval. Why it is called rotator cuff interval? Because there is a gap on the either side. The bicipital, the tendon is going intracapsular there. And along the side of the bicipital tendon, you can inject something intra-articularly. So I will be discussing this also when we'll be demonstrating there. And we also will be mentioning there, as I was mentioning, that thickness of the coracohumeral ligament. So this is the coracohumeral, this was the coracohumeral ligament. Coracohumeral ligament. So this coracohumeral ligament thickness, that can be also one of the aspect of diagnosing the frozen shoulder or adhesive capsulitis. But again, it's not very sensitive. There might be some misleading reports are there. But again, still, classically, many people use that thickness, measuring the thickness of that. So if you are holding the probe this way, so one end of the probe will be having the supraspinatus muscles, another end of the probe will be having the subscapularis muscle. Along the we'll be having the coracohumeral ligament, and in the middle we'll be having the biceps, long head of the biceps tendon. So these are the different, this is anterior, the subscapularis and the supraspinatus. Now, if I'm coming posteriorly, two muscles. One is this was your infraspinatus, originating from the infraspinatus fossa and getting attached with the middle facet. And below that, we are having another muscle, that is your teres minor muscle. And teres minor muscle is one thing you have to remember. I'll be showing you, demonstrating you also. Look at this teres minor. Teres minor, let me remove the infraspinatus. Now, hiding the infraspinatus, you can see the joint capsule. So when we'll be seeing the humeral head, that is the area where we'll be getting the infraspinatus. But if you're coming below, when the humeral head is basically almost completing, then only we'll be able to see the teres minor. That is the reason why many people find it difficult to get the teres minor muscles nicely. So let me remove the teres minor muscle as well. And another important thing sort of will be demonstrating there. This is particularly important to understand the supraspinatus. I'm removing the supraspinatus, supraclavicular nerve. Let me add the nerves now. I'm adding the nerves. So you see, this is let me reduce a little bit. So this is your suprascapular notch. And through the suprascapular notch, this was your suprascapular notch. The suprascapular nerve was coming. This was the ligament under which it is coming. And then it take a curve and it comes here. Here, it gives the muscular branch to the supraspinatus. Then it comes down and then muscular branch to the infraspinatus and the teres minor. And articular branch, let me remove this drawing. Articular branch, which is supplying the capsule,
See, this is the articular branch which is going to the supply the capsule. So if we are holding the probe here and blocking here, this is your spinoglenoid notch. This is your glenoid. This is your spinous process. So this notch is spinoglenoid notch. So if you are holding the probe here, and if we are able to see the this notch on the lateral aspect of this notch, we can block it so that the muscular branch will not be damaged. Muscular branch will be saved. So this is one of the suprascapular nerve block in the suprascapular notch is nowadays obsolete. We don't block the suprascapular nerve at the suprascapular notch. We block the articular branch of the suprascapular nerve at the spinoglenoid notch. So another important thing here, what I'll be showing you there as well is your let me add the vessels also, arteries. So here this nerve is your axillary nerve. So this is the quadrangular space where we'll be able to see, this is at the junction of the head and the shaft. At that junction, just below the teres minor muscle, this quadrangular space where we'll be able to see this axillary nerve going laterally. So here also, axillary nerve also posterior lateral part of the joint is supplied by the axillary nerve, and axillary nerve is also very important. Articular branch of the axillary nerve is also very important target when we are doing the denervation of the glenohumeral joint pain. So that is also important target for us. And another important target is here above the coracoid. So though it is not seen any branch here, but this is a very fine branch where the lateral pectoral nerve, this is the lateral pectoral nerve. This gives some articular branch which goes here and supply the joint capsule over the coracoid. So to block the articular branch of the lateral pectoral nerve, we press the RF probe or cryo probe over the coracoid process to block the articular branch of the lateral pectoral nerve, which normally takes care or carry the anterior shoulder pain. So if somebody is having the anterior shoulder pain, then articular branch of the lateral pectoral nerve is your target. And there we place the probe over the coracoid and we ablate there. So these are little bit of anatomy, and after that I'll be demonstrating it. Whatever I have shown you, I'll be again demonstrating later on. But in between, Dr. Series will be showing you the clinical part as well as the ultrasonographic, some of the pictures of the ultrasonographic diagnosis of the different shoulder pathologies. So Series, are you ready?
Yes, sir.
Okay, I'm stopping sharing so that you can share. Okay, Series, your slides are visible. You can make it full screen.
Yes, is it full screen now, sir?
Okay, you might be having some questions based on the anatomy. And if you are having the questions, you can, before I am starting the demonstration, you can again ask me those questions. And after that, I'll be starting scanning. Okay, Series, you can go ahead.
Good afternoon, everybody. I'm Dr. Sirish. I'll be talking about common shoulder pathology. It is easier now to correlate with anatomy and pathology because sir has quite beautifully showed the 3D diagram. So it is easier for me to start the pathology part of the shoulder. Okay, starting with so normally the shoulder pain is very much common in pain clinic. It is estimated that it is the third most common cause of musculoskeletal presentation in pain clinic. The first one being low back pain, second one is knee pain, and third one is the shoulder pain. And there is one systemic review done by the Lucas et al. Regarding the global prevalence of incidence of shoulder pain. And they have said that the significant population portion of the population population is having shoulder pain, they might experience shoulder pain daily, yearly, or throughout the lifetime. And normally the lifetime prevalence of shoulder pain is about 70%. And in the shoulder pathology, pain is not only the issue, it also causes the functional disability of the patient, leading because of inability to do work or carry out the hobbies, sports-related activities. Patient might get psychological stress, or they might have a very less, it might decrease the quality of life of the patient very much. And it also provides, it also causes huge financial burden to the individual, family, society, and as a whole nation itself. So coming to the anatomy of shoulder joint, sir has already beautifully explained the anatomy of shoulder joint. I just want to add only one thing in that, is that shoulder joint is a unique type of joint in which mainly the head of the humerus is a big and the glenoid cavity is very shallow. So there is a fine balance between the range of motion and its stability. So sometimes in shoulder joint, the shoulder joint may sacrifice its stability to get the full range of motion. So because of this, there can be many, like dislocation of the shoulder joints are very much common in day-to-day activity, and other parts such as joints, ligaments, and muscle, and the synovial cavity, as well as rotator cuff interval, has sir has very nicely shown. So I would like to skip this and go in front. So coming to the causes of shoulder joint, as I've already told, shoulder joint is one of the third most common musculoskeletal presentation, and the causes can be divided into traumatic and non-traumatic part. So traumatic cause of shoulder pain is usually secondary to fracture of various bone that it is associated with, such as fracture of humerus, clavicle, scapula. Dislocation is much more common in shoulder joint, and sometimes acute ligament sprain, such as a ligament sprain of this coracoacromial ligament, coracohumeral ligament. If there is any acute sprain secondary to direct trauma, this can be a traumatic cause of shoulder pain. And another most important cause of shoulder pain is a non-traumatic cause, and this non-traumatic cause of shoulder pain is divided into intrinsic cause, that is causes which is inside the shoulder joint complex, and another is extrinsic cause, that is pain which is usually secondary to outside the shoulder joint pathologies. So coming to intrinsic cause, it is again further divided into glenohumeral cause, that means cause inside the shoulder joint proper, and extra glenohumeral cause, that is pain which originates from the shoulder joint complex, but not itself from the shoulder joint proper. So the common cause of glenohumeral joint are, if you start from upside, it can be the subacromial bursitis followed by subcoracoid bursitis. And if you go further down, there can be a rotator cuff tear, and tendinopathies are very much common. If you go further inside the shoulder joint, then the glenohumeral arthritis and instabilities are also commonly pain generating pathologies. And finally, the labral tears are also commonly encountered in day-to-day practice. And another causes of extra glenohumeral cause of shoulder pain are the AC joint arthritis, which is very much common. Bicipital tendinopathy and tears are also commonly encountered. And finally, the subscapular bursitis or scapulothoracic bursitis, which is also known as snapping scapula syndrome, that are also commonly encountered. So, and coming to the extrinsic cause, that is outside the shoulder joint complex causes, are basically the pain which comes from disc herniation, mainly the cervical region disc herniation, impinging the cervical 5 and 6 nerve. Cervical spinal canal stenosis can be an important cause. Post-herpetic neuralgia involving cervical 4, 5, and 6 are also commonly encountered. Complex regional pain syndromes of the upper arm and shoulders are also one of the causes. Long thoracic and suprascapular nerve neuropathy are also common. And sometimes referred pain can also be there, such as like pain originating from the heart, such as secondary to myocardial infarction, or when there is diaphragmatic irritation, that can also cause shoulder pain. Intrathoracic tumor can also mimic shoulder pain. And another most important is myofascial pain syndrome, especially the trapezius muscle, because trapezius muscle, as well as with the greater pectoralis muscle and other muscles, are also a part of muscles which stabilize the shoulder joint. So you can see there are multiple pain generators in the shoulder, and most common causes are basically the rotator cuff and subacromial structure. And I have just shown you the table where there are multiple pain generators in the shoulder. These are the list that I've provided are the commonest cause that will be encountered in our clinical practice. That is glenohumeral joint osteoarthritis, AC joint osteoarthritis, subacromial subdeltoid bursitis are very much common. Supraspinatus tendinopathy and tears are also common. Bicipital tendinopathy, biceps tendon instability, and last but not the least, the frozen shoulder. Many patients with frozen shoulder come in the pain clinic. And while examining the shoulder, we should always follow the specific paths. That is mainly we should go for first history, followed by physical examination, and there are certain special tests that we usually follow for the examination of shoulder joint. But while taking history and physical examination, we should always be very careful. We should be paying attention to the red flags that might be there, which warrants for immediate referral of the patient to the other like orthopedic department or other subspecialty for the management. The red flag in the shoulder joint pain are pain secondary to trauma, especially if it involves fracture of the humerus, clavicle, or scapula. Dislocation of the shoulder joint are also the red flag which we should be careful. Tumors in the shoulder joint, septic shoulder joint, or infection in the shoulder joint, or unexplained sensory and motor deficit, as well as pulmonary and vascular compromise are the condition in which we have to look in the early part of examination of the patient, and if it is present, we have to refer the patient. So this is the flow chart which is I usually follow in my clinical practice. This is published in our book of clinical methods in pain practice, written by Sir Gautam Das. And in my days of fellowship, as well as nowadays also, I usually go through this algorithm to evaluate the shoulder pain. So if anybody with shoulder pain comes, we first have to ask the history, and in history they will give us certain clues like in any other disease, like age of onset, how it started, where the pain is, what are the aggravating factors, what are the relieving factors. These are all important. And after the history, we can and physical examination is equally important. And when we do the history and physical examination, normally we come into three different categories. First one is if there is any red flag, we have to refer the patient urgently. And second, if there is no red flag, then we have to ask whether it's we have to, by the history, we would know that whether the shoulder pain is traumatic or atraumatic. If the shoulder pain is secondary to any trauma, then patient usually gives history of localized pain. There is usually restrictive range of motion, both active and passive, and sometimes there can be weakness of the rotator cuff muscle. If there is something like that, we have to order the X-ray, because normally the bony pathologies of the shoulder joint are usually not seen in the ultrasound picture. So in this condition, we have to take the guide of X-ray. We usually take AP view and axillary view of the shoulder joint in order to find out any fractures or dislocation in the shoulder joint. And if there is any fracture of clavicle or humerus or any other thing in the shoulder joint, or if there is any, if you suspect any acute sprain of acromioclavicular joint and other ligaments, then we have to refer to the orthopedic, our colleagues. But if the X-ray is normal, then we can regard this traumatic cause of painful shoulder as an intrinsic cause of the shoulder pain. That is atraumatic or traumatic but intrinsic cause of the shoulder pain. And if there is no history of trauma trauma in the patient, then we usually go to the algorithm of atraumatic causes of shoulder pain. And as I've already mentioned in previous slide, basically atraumatic causes are either extrinsic cause originating from the neck, as such as disc prolapse or canal stenosis or postoperatic neuralgia, or even suprascapular nerve entrapment. Okay, and another one is intrinsic cause. In intrinsic cause, here the physical examination is very much important, and for to guide us or to pinpoint what are the intrinsic factors or causes of the shoulder pain, you usually go with a range of motion. Has to be checked of the patient. Normally, we usually see abduction, flexion, extension, internal rotation, and external rotation of the patient. Both active and passive range of motion has to be examined. And normally, if the cause is glenohumeral, then the patient is usually complains of pain in active or pain or restriction of the active range of motion. There can be restriction of passive range of motion, not all, but some. And usually there is a history of stiffness. And if you are thinking of extra glenohumeral cause, then usually pain is localized to specific sites. For example, if the pain generator is AC joint arthritis, then the patient will usually complain of pain in the superior part of the shoulder joint. And other extra glenohumeral cause, that is bicipital tendinitis. If the patient has bicipital tendinitis, then he will usually point in the anterior aspect of the shoulder joint. And in this extra glenohumeral causes, normally passive range of motions are normal, but there can be some restricted active range of motion. So after this slide, this is another flow chart, which is basically the continuation of the previous one. If in case of glenohumeral cause, the first thing you have to check in shoulder joint while doing examination is range of motion. Both active and passive range of motion has to be checked. If both active and passive ranges of motion are restricted, then the causes of shoulder pain might be inside the joint, that is glenohumeral arthritis or adhesive capsulitis. In between these two, usually in adhesive capsulitis, the range of motion is restricted more than that with glenohumeral arthritis. And this can be differentiated by simple X-rays. We can do the X-ray of AP view and axillary view, and just to see if there is any osteoarthritic changes in the shoulder joint. Similar to that, we checked in knee. And apart from X-ray, nowadays people are shifting to ultrasound in diagnosis of both adhesive capsulitis and glenohumeral arthritis. In glenohumeral arthritis, in palpation, we can also feel some crepitation in the patient. So, if both active and passive range of motion are restricted, and if you suspect adhesive capsulitis or glenohumeral arthritis, then management can differ based upon the diagnosis. But the beautiful part of the shoulder pathology is that most of the shoulder pathology usually resolves with multimodal treatment of drugs and physiotherapy. And if needed, ultrasound guided injection provides excellent result in these patients. And so first is checking the active and passive range of motion in case of glenohumeral cause. Another scenario might be the patient can have a restricted active range of motion, but the passive range of motion may be normal or restricted. In these conditions, the pathology may be the impingement. So initially, impingement used to be a single diagnosis, but nowadays impingement usually covers a spectrum of diagnosis, which includes like subacromial bursitis, rotator cuff tendinitis, or even rotator cuff tear. So how to differentiate in these three are basically by doing the muscle strength test, and there are certain special tests in the shoulder joint examination which you have to know very nicely. So after the range of motion, checking the range of motion, we check the muscle strength. If the muscle strength is less, then, or there is weakness in muscle strength, then our diagnosis goes towards the rotator cuff tear. And we can check the rotator cuff muscle strength by doing like empty can test or belly press test has to be done, or extensor lag test. These are the special tests which are usually done in to differentiate whether it's a rotator cuff tendinitis or if there is a rotator cuff tear. Sometimes what happens is because of pain, patient might have weaknesses of muscle, or patient might have restricted passive range of motion. In these conditions, we can simply inject local anesthetic solution in the subacromial subdeltoid bursa, either blindly or USG guided, and we can check the response. In true rotator cuff tendinitis, after giving local anesthetic agent in the subacromial bursa, the range of motion, passive range of motion will improve. Similarly, the muscle strength will also improve. But if the pathology is rotator cuff tear, then the weakness will remain same even after giving local anesthetic solution in the subacromial subdeltoid bursa. So, if your diagnosis has been narrowed down to subacromial bursitis or rotator cuff tendinitis, and this can be easily seen by the ultrasound, which will be present in the pain clinic, just by putting ultrasound in the specified structure, like in subacromial region or in the rotator cuff area, we can pinpoint the diagnosis and go for the further management. Similarly, in case of rotator cuff tear, we can use either ultrasound, or if you are not comfortable with ultrasound, we can also advise MRI, which can basically diagnose whether it's a full thickness tear or partial thickness tear. In case of full thickness tears, we basically refer that patient to the orthopedics or concerned colleagues for the repair. But if it's partial tear, then it can be resolved with conservative therapy by, and nowadays we are giving lots of PRP in this partial tear of supraspinatus and other muscle and have an excellent result. So these are all how to identify or how to pinpoint the exact pathology in case of glenohumeral cause. Now coming to extra glenohumeral cause, that means pathology is outside the shoulder joint, but within the shoulder joint complex itself. So most commonly encountered problem are the AC joint pathology and bicipital tendinitis. In both of these extra glenohumeral causes, patient usually pinpoints the area of tenderness, such as in AC joint, they will show at the superior aspect of the shoulder joint the pain, and in case of the bicipital tendinitis, they will show at the anterior aspect of the shoulder joint. And there are few special tests which can further pinpoint the diagnosis. For example, in case of AC joint pathology, we can go for passive horizontal adduction test, where the patient is asked to do the horizontal adduction to the opposite side, like how you are wearing a scarf. This is also known as scarf test. And when we tie the scarf or muffler around the neck, we usually do the horizontal adduction and touch the opposite side of the shoulder. This maneuver will cause pain in case of AC joint pain. And if there is a bicipital tendinitis, speed tests are usually done. And another beautiful test is Yergerson test is done usually to determine whether it's a bicipital tendinitis or not. And if there is a pathology identified, then nowadays ultrasound guided injection, steroid injection are commonly used for the relief of pain. So there are, as I told you earlier, history and physical examination is key point for diagnosis of shoulder pain, not only shoulder pain, for any other diseases. So clues on shoulder, clues that we can generate while asking history are, if the patient has glenohumeral osteoarthritis, patient's profile is usually advanced age, and here there will be decrease of range of motion, both active and passive will be less. There can be stiffness in the joint, and patient usually tell that there is pain while putting on a seat belt. That means abduction, external rotation, and internal rotation. This maneuver will cause pain in the patient, or reaching behind the back while you try to reach behind the back, this will cause pain in the shoulder joint. So this usually guide us to think that there might be a glenohumeral osteoarthritis might be there. And in case of frozen shoulder, it is similar to glenohumeral osteoarthritis, but patient profile usually will be middle age, not always, but usually in the middle age. Patient might be having diabetes mellitus in their history, because in diabetic patient, there are about 40 to 50% diabetic patient can have a spontaneous frozen shoulder. In the main differentiating point between frozen shoulder and glenohumeral osteoarthritis is the stiffness. In case of frozen shoulder, as the name suggests, there will be marked or progressive stiffness in the patient. And another clue that we can identify in the shoulder history, in case of rotator cuff pathology, is that pain is usually referred to the lateral aspect of the arm, and pain usually occurs when there is overhead activities, such as because of impingement. So how impingement occurs? When the head of the humerus, when it impinges the subacromial subdeltoid bursa and supraspinatus muscle to the arch of coracohumeral arch or acromial, then it will cause pain. And this maneuver is usually happens when we try to reach up and change the bulb. Like if you do this kind of activity, reach your hand up and change the bulb. This is the maneuver that will cause impingement of the bursa as well as muscle between the head of the humerus and acromial arch. And I have already told, in long head of biceps, there will be anterior shoulder pain, and in AC joint osteoarthritis, patient usually refer to the superior shoulder joint as a pain marker. So these are a few special tests that you have to know. There are lots of special tests, but these are the few special tests that is usually done in our clinically to identify the pain generator. So, but you have to know that most of the special tests are not sensitive or specific. So first one, AC joint pathology. Patient usually complains pain in the scar when the cross body adduction test is done. That means if the patient is told to passively adduct the arm and reach the opposite side, then they will have pain in the AC joint. Another test is speed test, where the patient's hand is flexed to 90 degree, elbow is also extended, and forearm supinated. If we apply downward force to the supinated hand, then the patient will complain pain in the anterior aspect of the shoulder. Empty can test is an important test which we have to do in almost every patient, just to check the strength of the muscle. Mainly empty can test is done to check the strength of supraspinatus muscle, and O'Brien tests are basically done to check the labral and glenohumeral joint pathologies. So this is on another flow chart that I have shown, which shows the first range of motion being checked, active range of motion, followed by a passive range of motion. Then after range of motion, we have to check the rotator cuff strength, that is muscle weakness, followed by few special tests, which will guide us to the specific pinpoint pathology that the patient is having. So now comes the role of ultrasound in shoulder pain. Ultrasound has a tremendous role in diagnosing, both diagnostic and therapeutic purpose of the shoulder pain. So as we know, majority of pain generators can be visualized with the help of ultrasound in the pain clinic itself. Previously, before ultrasound, we used to rely on X-rays for the diagnosis as well as for the therapeutic purposes. But nowadays, within the pain clinic, by sitting inside the pain clinic, you can diagnose most of the shoulder joint pathology using ultrasound. And this is also cheap. Like previously, we used to go for MRI for any shoulder joint pathologies. But nowadays, by ultrasound, we can show it to the patient in real time, and we'll be saving lots of money of the patient, but not for of us, but of the patient. Another important role of ultrasound in pain is dynamic assessment. As sir has already told that for normally in AC joint, if there is any subluxation of the AC joint, dynamic testing of the AC joints are done to see whether there is subluxation or not. Similarly, dynamic assessment of the shoulder joint, especially when we are examining the adhesive capsulitis or frozen shoulder, this can be a very useful tool, the ultrasound. And as we all know, safety are very much less with the use of ultrasound. There is no X-ray or CM radiation while using ultrasound. And normally the ultrasound in the shoulder joint doesn't contain any major blood vessels and nerve. So dire complications are extremely rare while injecting drugs into the shoulder joint. We especially have to think about, there is one vessel known as ascending circumflex humeral artery, which will be very near to the long head of biceps. Only that thing we have to check in, we have to bear in mind while injecting in the bicipital groove. Otherwise, there is not much significant blood vessels or nerve which we be encountering while injecting. And with the help of ultrasound, we can easily see the structure inside the shoulder joint and give injection inside the shoulder joint and prevent injection in the labrum, or in the hyaline cartilage, or even in the tendon. Okay, but so there are some, having said that, there are some limitation, especially the limitations are when there is a problem inside the bone. For example, if there is any bony structural abnormality, then maybe X-ray plain X-ray are much better than ultrasound. For example, in case of osteoarthritis, it's easier to diagnose osteoarthritis of the shoulder joint using X-ray rather than ultrasound. But nowadays, people are coming with various modalities of ultrasound, which I'll be showing in slide later on, which we can predict if there is any osteoarthritis of the shoulder joint. Similarly, complex ligament and cartilaginous structure problem are also less visualized by ultrasound, especially the labral tear, especially if there is a superior labral and tears, or if there is any complex labral tears or complex ligament tear, then maybe MRI will be much more beneficial than ultrasound. So keeping this in mind, we usually evaluate the patient in various positions that I have listed in this slide. Normally, we evaluate the glenohumeral, the anterior shoulder pathology, long head of biceps, subscapularis, and AC joint in the first position. That is, patient is sitting position, shoulder with a neutral position, elbow flexed and supinated. Another position are shoulder internally rotated with elbow flexed and supinated. Another main position is shoulder with external rotation but elbow flexed and supinated. Another is patient holding the opposite side of the shoulder, that is scarf position. And finally, the CRAS position and modified CRAS position are also very important to see the supraspinatus and subacromial subdeltoid bursa. Patient, usually when we examine the patient, shoulder patient, we allow the patient to be examined in the sitting position with rotating chair, so that he can be examined from all the part. And usually those chairs which doesn't have backrest or support are preferred while examining the shoulder joint. So coming to first, that is subacromial subdeltoid bursa. Actually, this is the most commonly injected site in the shoulder, mainly for diagnostic purpose as well as for the therapeutic purpose as well. So I've already mentioned the diagnostic purpose. When you are in dilemma whether the weakness is true weakness or false weakness, or when you are in dilemma whether the passive range of motion is restricted, truly restricted, or it is restricted due to pain, we can simply inject in this subacromial subdeltoid bursa using ultrasound and check again. This will clear off our diagnosis and help us to accurately pinpoint the pathology. Secondarily, it can also be used for the therapeutic purpose also, such as in case of rotator cuff pathologies like tendinopathy, impingement syndrome, or in case of subacromial bursitis, then subacromial subdeltoid bursa are commonly injected. So this is the ultrasound picture that I have incorporated showing the subacromial subdeltoid bursitis. The picture in the left side of the screen is the normal picture that you will be seeing when you put the patient in the, when you view the ultrasound of the subacromial bursa and supraspinatus. Normally, the position of the patient would be sitting with crass or modified crass position. And when we put our ultrasound parallel or in the long axis of supraspinatus tendon, then you can see these three basically structure. First one in the left side, upper one is the skin and subcutaneous tissue, followed by the deltoid, and lastly the lower one is supraspinatus tendon. It is usually seen as a bird beak appearance, and you can nicely see the hyperechoic fibrillar pattern of supraspinatus getting attached to the upper facet of the greater tubercle. So in case of and normally the subarachnoid subdeltoid bursa are located just between the deltoid and supraspinatus muscle as a thin layer of an echoic line. But if there is any bursitis, then in the left side of the slide you can see the picture of the fluid getting accumulated in between the deltoid and supraspinatus, and we can easily see this in ultrasound. And as shown in the picture, in the white arrow marks, between the two white arrow marks, there's an anechoic area spreading between the deltoid and supraspinatus. We can easily put the needle in the in-plane axis as shown in the picture and inject like local and steroid to relieve pain. So this is one of the most commonly used procedure that we'll do in pain clinic. So this is another supraspinatus pathology that I wanted to show. Here also in the left side, I have compared with the normal slide, and in the right side, there is a pathological part. And in the right side, in the upper right side, you can see the normal homogeneous hyperechogenicity and fibrillar pattern of the supraspinatus is lost. And you can see the mixture of hyperechoic and hypoechoic structure in the supraspinatus. And if you put on a color Doppler, you might as well see a lighting up of the screen with color Doppler, mainly because of the neovascularization and inflammation. So these are the signs of supraspinatus tendinopathy. And in the lower part of the right side of the screen, you can see a calcific deposition in the substance of the supraspinatus tendon. And you can also see the artifact like acoustic, post-acoustic shadow can be seen below the calcific tendinitis part. So moving on, this is the picture of the various type of tear of supraspinatus, starting from left side to the right. The left side of screen, you are seeing the articular side tear, and this is the, if you see the upper left side, you can see the fibrillar pattern is lost, and there is a black anechoic area just at the articular surface. So this is the articular side tear of supraspinatus. And in the middle part of the slide, in the upper middle part of the slide, I don't know whether it's clearly visible, but you can see where the needle is placed. You can see hypoechoic patches within the substance of the supraspinatus, and just below that picture you can see the PRP after giving PRP, the white hyperechoic area, that is PRP after giving PRP in the substance of supraspinatus. So, and finally at the right side of the screen, you can see the tear in the bursal surface that is near to the subacromial subdeltoid bursa, and the injection being given into the tear. So these are the three different type of supraspinatus tear that you may encounter in your clinical practice. So this is another slide which clearly shows the supraspinatus tear. So upper part of the picture, I have compared the picture with the right and left side of the right and left side of supraspinatus of the same person. I forgot to tell in the earlier part, when we are examining the patient of shoulder, not only shoulder, but most of the part, we always have to examine the normal side and compare to the pathological part. This is especially advised for the beginners like us. So here in the picture you have seen in the upper part right side, the normal supraspinatus of the left side of the patient is being shown, and you can see normal hyperechoic fibrillar pattern of the supraspinatus. But if you compare this with the left side, then you can see a black anechoic part within the substance of the supraspinatus, which shows the tear in the supraspinatus. And in the lower part of the picture, left lower part of the picture is a normal supraspinatus tendon. But here you may see a black area at the site of insertion. That is basically an anisotrophy, which is commonly encountered while scanning the tendon. And when you see this anisotrophy, you have to slide your probe upward, downward, tilt, angulate, just to see the change in the architecture of the ligament of the tendon. And in the middle lower part, you can easily see the torn supraspinatus tendon. Here you can see black anechoic area at the attachment of the greater tubercle of the humerus. And finally, in the left side of the screen, you can see a big area of anechoic area that basically shows full thickness tear of the supraspinatus muscle. Moving on, so coming to the long head of biceps tendon, long head of biceps tendon tendinopathy are also commonly encountered in our clinical practice. And the long head of bicep tendon has two portion. One is it has an intra-articular portion and it has an extra-articular portion. And as sir has already told, that it arises from the superior part of the glenoid labrum as well as glenoid superior glenoid tubercle. And once it originates, it descends downward and forward, and it enters into the bicipital groove in an angle of 30 to 45 degrees. And this is the area where it is commonly injured. Most common problem that we can encounter is tendinopathy, either transverse or longitudinal split of this long head of biceps tendon. Slap lesions are commonly encountered, and complete rupture of the long head of biceps are also seen commonly. So in this slide, in the upper part, there is a pictures of various pictures of tendinitis. So here in the upper left side, you can see a normal long head of biceps in the bicipital groove and subscapularis. But just adjacent to that, you can see long head of biceps tendinitis, tendonitis, where you can see an anechoic fluid surrounding the biceps tendon. And this fluid is in between the tendon sheet and the main long head of biceps. And if you put on a color Doppler, you may see like lighting up the color Doppler because of the inflammation. And you always have to scan both short axis and long axis view of any muscle or tendon that you are examining. And in the lower part of the slide, here you can easily see the bicep with long head of biceps tendinitis in a short axis view in the left side and in the long axis view in the right side. So if you see this, you can easily identify with ultrasound and inject the drug inside the fluid or cavity. Another commonly encountered problem in clinical practice is complete rupture of long head of biceps. And in inspection, if there is a complete rupture of long head of biceps, you can see a Popoi sign. That means the whole of the bulk of the muscle is down with, and you can easily see the muscle bulk in the lower aspect of the arm. And this is the diagrammatic view also, where you can see the tearing of long head of biceps at the site of origin. And in the lower part of the slide, you can see a beautiful panoramic view of the normal bicep muscle as well as the complete tear of bicep muscle. In the upper part of this panoramic picture, you can see the head of humerus in the left side. And just above the head of humerus, you can see the tendinous part of the biceps muscle going down, and comes the myotendinous junction just below the deltoid muscle, and whole bulk of the biceps muscle starts. But if you just compare this diagram with the lower part, you can see the continuation of the tendinous part of the bicep muscle is lost, and in between the tendon, torn tendon and retracted muscle, there is a big hematoma. So this can be easily identified with the ultrasound in our clinic, in the pain clinic. And if there is complete retraction and tear, we have to refer to the patient to the orthopedic doctors. And another problem that we commonly see is acromial clavicular joint problem. And acromial clavicular joint is one of the most superficial joint. You can easily palpate this joint as if you trace your clavicle and go distally, you can suddenly see the stepping off of the clavicle. That is the acromioclavicular joint. And it is also a synovial joint, which with the superior joint and inferior joint capsule. And just below the acromial clavicular joint is AC joint is the acromial and subdeltoid bursa, followed by the supraspinatus muscle. And this is the diagrammatic or a view of the AC joint. In the left side, there is a common probe position to see the AC joint. And in the right side of the picture, there is a normal ultrasound picture of the AC joint. And in the lower part of the picture, there is like you are seeing the AC joint, and one intervention, that is this out of plane injection of the AC joint has been demonstrated in the lower slide. So these are some clinical pathologies that are seen in AC joint. In the upper part, you can see effusion in the AC joint, and you can see distended capsule, superior capsule of the AC joint, as shown in the diagram E. E is written for effusion. And if you see the below slide, there are two pictures, one with effusion, both with effusion and osteophytes at the distal part of the clavicle and proximal part of the acromial. So this is commonly seen in the patient with osteoarthritis or those patients with painful AC joint. These pictures are very commonly seen in the clinic. Another commonly encountered problem in our clinical practice is adhesive capsulitis. And adhesive capsulitis, as we all know, another common name is frozen shoulder. It is basically an inflammatory disorder of the rotator cuff interval. So what are the content of rotator cuff interval? It basically includes the long head of the intra-articular part of long head of biceps, followed by superior glenohumeral ligament, followed by coracohumeral ligament and the joint capsule. So these are the part of the shoulder rotator cuff interval. And when there is inflammation in these rotator cuff content of this rotator cuff interval, then it is called adhesive capsulitis. And it is quite common. Normally 2 to 3% of the population usually have adhesive capsulitis. Female are more prone to have this, and also the diabetic patients are more prone to have this adhesive capsulitis. Usually in adhesive capsulitis, the X-ray of the shoulder joint is normal. And in the past, we used to diagnose this in the basis of experience, or we usually go for MRI imaging. But nowadays, this adhesive capsulitis is usually diagnosed using ultrasound. And there is one study done by Anupam, Mr. Anupam and Sakshi regarding sonography of diagnosis of adhesive capsulitis. And in this study, they have including two different parameters. One is static parameter, and another is two dynamic parameters. So I'll be showing this in the following slide. So this is one of the study which was done by Anupam and Sakshi. One of the criteria was to see the thickening of coracohumeral ligament, as sir has also told in the class, that we measure the thickness of the coracohumeral ligament usually to diagnose the adhesive capsulitis. And normally the thickness is 0.7, less than 0.7 millimeter. If the thickness is more than 0.7 millimeter, then we diagnose it as a adhesive capsulitis. Normally, the probe is placed, one end of the probe is placed at the coracoid process and another over the head of the humerus, and we tell the patient to externally rotate the arm. This will stress the coracohumeral ligament, and you can nicely see as shown in the picture. You can see the arrow mark and the asterisk mark. and a small anechoic area in the picture A, extending from coracoid process to laterally. So this is the coracohumeral ligament. And in case of adhesive capsulitis, you can see in the lower part of the picture, there is the acromioclavicle ligament is thickened. And this is one of the diagnostic criteria for adhesive capsulitis. Another diagnostic criteria for adhesive capsulitis is to see the soft tissue thickness in the rotator cuff. And the sensitivity of this test is about 86% and specificity is about 94%. And in this slide, if you see the left side, that is a normal ultrasound picture of the rotator cuff interval showing all the different content. Like in the left side, it is boundary left, or in the upper part, it is bounded by supraspinatus muscle. In the lower part, it is the boundary is subscapularis muscle. And in between these two, there is a long head of biceps. So this along with coracohumeral ligament and superior glenohumeral ligament is a part of the rotator cuff interval. And in case of adhesive capsulitis, you can see, as in the picture shown in B and C, you can see there is increased soft tissue in the rotator cuff. This also signifies that this is one of the diagnostic criteria, ultrasound diagnostic criteria for adhesive capsulitis. And if you put on the color Doppler, like it is shown in the slide, the lowermost slide, you can see the lighting up of the color Doppler, which basically shows an inflammation of the rotator cuff interval. So another test that the study has done is checking the dynamic scanning of the shoulder to diagnose the adhesive capsulitis. So with ultrasound, we can easily see the dynamic maneuver of the muscle and joint, and it will be easier for us to diagnose. Okay, so in the left side of the slide, the dynamic movement of the normal and that with adhesive capsulitis is shown. In the left upper part, you can see the supraspinatus muscle coming out of the acromial and getting attached to the greater tubercle. And when you abduct the arm, then you can see easily the whole of the supraspinatus going inside the acromial. But if there is a frozen shoulder, you will see only partial entry of supraspinatus inside the acromial. You can still see some part of supraspinatus tendon outside the acromial, as the patient cannot do the active as well as passive abduction. Similarly, another dynamic scanning of subscapularis can also be very helpful in diagnosing the adhesive capsulitis. In the right side of your screen, the upper part is the normal rotation of the subscapularis, and the lower part is the restricted rotation of the subscapularis. And in upper part, you can easily see the whole of the subscapularis being rotated to the side while doing the dynamic scanning. But in the lower part of the right side of the screen, you can see there is a partial movement of subscapularis. The whole of you can see the attachment lesser tubercle in both when the patient is externally rotated, when it started and when it ended. And this is the dynamic scanning which we commonly use to diagnose the adhesive capsulitis. So coming to glenohumeral joint osteoarthritis, as I have told, classically it is diagnosed with X-ray, and here in the slide you can see the normal shoulder X-ray in the left side as well as the osteoarthritic X-ray in the right side and in the middle. In the left side you can see the good space. There is a very good space between the head of the humerus and the glenoid cavity. But if you see the middle and the lateral and the right side of the picture, you can see there is a marked loss of joint space between the humeral head and glenoid cavity. And you can also appreciate some osteophytes at the edges of the humeral head as well as the glenoid cavity. And so similarly, you can see the subchondral bone sclerosis, decrease in the articular surface in the X-ray, which usually shows the osteoarthritis of the shoulder joint. But nowadays we are using ultrasound to diagnose the glenohumeral osteoarthritis as well. And so this is one of the slides that I've taken where you can see the see the thickening of the hyaline cartilage you can measure the thickness of the hyaline cartilage of the head of the humerus, and then determine and see whether there is osteoarthritic changes or are there or not. Suppose if you see this picture in the right side of the screen, you can see a beautiful hyaline cartilage covering the head of the humerus, and normally the thickness of this humeral head cartilage is normally 1.77 plus minus 0.35 millimeter will be the thickness at the center, and in the superior and inferior aspect the thickness is about 1.42 plus minus 0.37, and we measure the thickness of this hyaline cartilage. If there is any reduction of the thickness of this hyaline cartilage, then we can suspect maybe the patient is having osteoarthritis of the glenohumeral joint. And you can see the position of the patient. Normally this picture can be achieved when the patient is in sitting position, shoulder in the normal neutral position, and hand externally rotated. And if you put the probe along the short axis of subscapularis, then you can easily see the head of the humerus, the hyaline cartilage, as well as subscapularis. And by measuring the thickness of the hyaline cartilage, we can come to the conclusion of osteoarthritis is there or not. So another commonly encountered pathology is glenoid labrum pathology. Labral tears are also quite common. So with the labral tear presents with very wide range of symptoms, and they are usually non-specific. And in labral tear, patient usually complains of pain and discomfort, but it is not at the specific site. They cannot pinpoint the exact site of pain and discomfort. But apart from pain and discomfort, there can also be joint weakness, joint instability, and we can also appreciate clicking sound because of the tear in the labral. The most common cause being acute trauma or repeated overuse can be a cause of labral pathology. Normally, the pathology depends where it is located. Like superior labral tears are there, anterior, inferior, and posterior tears are also there. Circumferential tears are also there. Although the ultrasound is used for diagnosis of labral tear, but if you think it is a complex labral tear is there, then it is always good to go for MRI, as it is a gold standard investigation to see the entire labrum. So this is a picture of the normal anatomy of the labral in the center, and you can see the circumferential tear in the labrum. And the lower part of the slide, you can see the how we can visualize the labrum. I am sure sir will be showing you the exactly how to appreciate the labral and posterior joint space as shown in this picture. Basically, we can, with this probe position, that is if the probe is placed just below the spine of scapula, and if we rotate this or slide this probe laterally, then we can see infraspinatus, the sphenoglenoid notch, as well as glenoid cavity and humeral head. And sir has also already spoken in last class. This is the labrum is a fibrocartilaginous structure, so you can see hyperechogenicity of the labrum. But just adjacent to it, there is a hyaline cartilage covering the head of the humerus, which would be hypoechoic. So this is how you diagnose hyaline cartilage and the fibrocartilage. And if you see nicely in the slide, you can see asterisk mark between the labrum and the hyaline cartilage. And this is the site of injection if you are going to inject in the posterior joint space using ultrasound. So this is one of the picture where you can see the tear in the V-shaped glenoid labrum, as shown by the yellow arrows. So another problem that we can encounter in the shoulder is paralabral cysts. So these are basically a small swelling arising around the socket of shoulder joint, and usually it is secondary to the tear of the labral tear. And normally these paralabral cysts doesn't produce any pain, but sometimes it can cause like pain and weakness, mainly when it is large and if it compresses the nerve that the sir has already explained. So there can be huge posterior labral cyst in the posterior aspect. This can compress the suprascapular nerve, either in the splenoglenoid knots or suprascapular knots, and their patient can complain of pain and weakness of the infraspinatus muscle. Similarly, the labral cyst can extend downward and compress the axillary nerve in quadrangular space, and this can cause weakness in the deltoid and teres minor, which is also known as quadrilateral space syndrome. So this is the ultrasound picture of the labral cyst. In the upper part, you can see the cyst arising from the labrum. Here, in all these three pictures, in the upper part, you can see the cyst extending along the glenoid cavity, and especially the lower part of the picture. I wanted to include this because here it shows the extension of posterior labral cyst and compression of this the suprascapular nerve by the labral cyst. In this condition, patient may complain of pain and weakness of supraspinatus and infraspinatus. There is a diagrammatic comparison between left side of supraspinatus as well as in the right side of supraspinatus, and just above the supraspinous knot you can see a black anechoic area cyst compressing the supraspinous nerve and causing neuropathic changes. Okay, thank you very much. So any questions? Hello. Hello. Sir, am I audible, sir?
Yes, Siris, you are audible. So it was very elaborate, and now it is time to go for the demonstration. I am sure that many people are waiting for the demonstration. So let me go ahead.
Yes,
Any questions,
yes,
whatever is there, I'll be requesting them to go for in the chat box, and you can go on answering in the chat box. Because we are already late, I don't want any question answer right now. So any questions what is having for the series, you can put it in the chat box, and the series will be going to answer it. So here you can see the volunteer sitting there, and also you can see the ultrasound probe. Series, can you see it? My slides?
I can see Sanjeev Da and picture, sir. Yes, sir, I can see it.
Right. Okay. So normally we start scanning with the biceps, long head of the biceps, and the probe here, what we'll be using is your what probe? Linear probe, right? And the home position, we normally start scanning from the humerus, just below the joint. So from here I am scanning, and what you can see here is your humerus. So the bone here was your, so this was your humerus, and above that this muscle is your deltoid muscle, and here is the biceps tendon. It is ready, tendinous there. So from there I'm going up. So from there I'm going up, and now you will be able to see the groove. You can see the U of the humerus is now getting. So one thing I forgot to mention, that my aspect marker is towards the left side of the screen. This side is your aspect marker. So this is the medial side, and this is the lateral side. So when I'm going up, gradually I am able to see the bicipital groove. And in the bicipital groove, what we can see there, greater and the lesser tubercle. And also see here, yesterday I was telling, here the bicipital tendon is looking hypoechoic. Why hypoechoic? This is a basic thing, that if the ultrasound beam is not coming back to the transducer, it will be looking hypoechoic. And now if I'm doing like this, you'll be seeing it hyperechoic. So
So this is now the tendon is looking hyperechoic. Let me reduce the depth a little bit. So this is the bicipital tendon, and this is your greater tubercle, this is your lesser tubercle. And if I am going up, this is the bicipital tendon. Now it is looking hyperechoic. At this position, I'll be looking at long axis. So this is the long axis view. So a tendon, how it will look? Tendon will look hyperechoic fibrillar. So this is the tendon in the long axis. Tendon is looking nice. So if there is dislocation or if there is a rupture, so this bicipital group might be looking empty. You may not be able to see anything. Above this, the muscle, what you can see here is your deltoid, anterior fibers of the deltoid. So this is your humerus at the bicipital group in the long axis. So now, if we put more gel, if I'm coming down, my aspect marker is again on the left hand side, that is medial side is your left hand side. If I'm coming down, see what is happening. So now here, this is your pectoralis major muscle. So this is the pectoralis major muscles getting attached here, and below here is your bicipital tendon, and it is getting attached over the humerus. This is the pectoralis major. So now from here I was going up, bicipital groove. Then here when I am coming here, so and at this position, this was your, this muscle is your subscapularis. Subscapularis in the long axis. But if I wish to see the subscapularis, and this is your coracoid process. This is your coracoid process. This is your subscapularis in the long axis. And if I wish to see the subscapularis, even better, subscapularis tendon. So whole thickness of the subscapularis is not nicely seen. This part is hyperechoic, this part is hypoechoic. If I'm doing a heel to maneuver, then I might be able to see it better. I see now it is subscapularis, is whole of this subscapularis is looking hyperechoic. And if I'm doing the external rotation, then what will happen? The subscapularis, still more portion of the subscapularis by access by the goda. You can see still more portions of the by the. So you see, this is the whole portion of the subscapularis tendon. You can see in the long axis. Now, if I am rotating it, so now my aspect marker is up. So here at this position, I can see the subscapularis. I can see the subscapularis here. This is now your subscapularis in the short axis. So what is important here? When you are seeing in the short axis, you can see there is hyperechoic, in between the hypoechoic, again hyperechoic. Don't think that this is pathological, because here we have to understand that it is your multipinnate appearance. So because of its multipinnate appearance, it might be looking like that, but that is not pathological. So short axis of the subscapularis muscles will be looking like that. So this was the short axis of the subscapularis muscle. This bone is your north-coracoid. This is your clavicle. So where you are having the long axis, then this is your coracoid. But in this axis, short axis of this the subscapularis muscle, this is your clavicle, and below that, this is the multipinnate appearance of the subscapularis muscle. So the biceps and the subscapularis. And now here I'll be showing you the supraspinatus and rotator cuff interval. So supraspinatus, where from it is originating, I have shown in the anatomy that if you are palpating the spine of the scapula, so above this is the spine of the scapula, which is becoming acromion. So above that, if I am putting my probe here, it will be coming below the acromion, and it will be below the acromion, it will be coming here. And there is a ligament, coracoacromial ligament, which completes the arch, through below which it will be coming here. So now, if we put a little more gel there, and let us see let me increase the depth a little more, because here, so where is my probe? My probe is above the, so if I'm going lateral side, this is your scapula. This is your trapezius. This is your supraspinatus muscle. So the more medial you are going, the thickness of the supraspinatus is less. Laterally you are coming, supraspinatus thickness is increasing. And look at this, we'll be getting the supraspinatus, notch here. This is the notch, suprascapular notch. So here you can see the pulsations there. So if you wish to block the suprascapular nerve at the suprascapular notch, this is the target where my probe is there. So you can see the pulsation there. So that is where you have to block it. But normally for the pain management, for the anesthesia purpose, that is okay. But for the pain, chronic pain management, if you wish to ablate you can see the pulsation there very nicely. So if you wish to do the permanent block, then you cannot block it there. Then the nerve to the supraspinatus, interspinatus, all this will go. So you cannot block it here. So now I am coming more laterally, and now you can't see anything because you are over the acromion now. You are over the acromion now. So now if we are coming still more, and if we are making the, so now what will happen? Now again, this was your acromion. Let me reduce the depth now. So this was your acromion, and this is your supraspinatus tendon. But supraspinatus tendon will be able to see it better if we are having the clasp position or modified clasp position. This is the modified clasp position. So this is how we can see the supraspinatus tendon is coming more, and this is your supraspinatus tendon in long axis. So this is the supraspinatus tendon in the long axis. And here, subacromial subdeltoid bursa, here there is no bursitis, but you can see a very faint black line within this white area, that is your bursa. So this is your supraspinatus tendon in the short axis, a long axis, sorry. And if you wish to see in the short axis, then you just make it like this. So this is your supraspinatus in the short axis. So here, what I was telling you like before also. So if you are putting your probe one side over the coracoid, this is your coracoid, and another side, another is your over the acromion. This is your acromion. And if you are coming below, so now this is your supraspinatus. So supraspinatus basically comes like this, And if you are coming still below, so this is what is your, so let me hold the probe this side. Now medial side is your otherwise there will be some difficulty in orientation. So this was your coracoid, this was your acromion, and this is your supraspinatus. So this side is your medial side. So this side is your subscapularis, and this side is your the supraspinatus. So now if I am coming down, so now you can see now the bicipital tendon. So roof is formed by, as I was telling you, roof was formed by the coracohumeral ligament. And on the either side of the coracohumeral ligament, this is the roof is formed by the coracohumeral ligament, and this ligament on the either side of the bicipital tendon, this and this is the superior spinoglenoid ligament. Superior glenohumeral ligament. As I was telling you, there are three glenohumeral ligaments: superior, middle, and the inferior. So this is your fibers of the superior, the glenohumeral ligament, and roof is by this hyperechoic area is that is what Siris was telling, by measuring that we can measure. But again, if you are searching the literature, exactly how much thickness and how much thickness should be the normal, how much thickness should be for the adhesive capsulitis, lots of debates. You just search the literature and see. Some literature says 2 millimeter, some say 3 millimeter, 1.7 millimeter, lot. So that is there is basically no definitive guideline or protocol at which thickness is normal, which is abnormal. But anyway, these black areas on the either side is your ligament, and this side is your subscapularis, this side is the supraspinatus, and the gap either side of that is your rotator cuff interval. So if you wish to go intra-articular injection, so what you can do is you can come and inject here, you can come and inject here, and this injected will be going inside the joint. So if you wish to go intra-articular joint, anteriorly you can go into the rotator cuff and you can inject there. And there also another thing you can do, if there is adhesive capsulitis, you can puncture this superior glenohumeral ligament on the other side of that. That means on here as well as here, you can puncture and you can do the fenestrations of the superior glenohumeral ligament and coracohumeral ligament as well. So This was your coracoid process. This your coracohumeral ligament. Some book also says there is some small fat pad hypoechoic area just medial, just lateral to the coracoid. This fat pad might be lost in the the adhesive capsule. So this is the anteriorly. These are 3 tendons. What you should look longer to the biceps. Medial side of that is the subscapularis. Lateral side of that is the supraspinatus. So now here 2 impingement tests or 2 impingement are common. One is subcoracoid impingement. So below the coracoid, the tendon what is passing is this is your coracoid. This was your subscapularis. So if I am holding the probe like this was your coracoid and this was your subscapularis. Now if I am rotating it, you can see that the greater tubercle is going inside. So this was your biceps tendon. It is coming, and this is your greater tubercle. So the lesser tubercle. So lesser tubercle is going below the acromion. This is the normal. But if there is a subcoracoid impingement, you see, this is the whole, the subscapularis muscle. If I am doing the external rotations, the subscapularis tendon is coming out. Greater tubercle is going far lateral, and if I am doing like that, so this was your biceps. So this was your biceps. This was your greater tubercle will be going below the coracoid. So this was your coracoid, it will be going below that. That is normal. So this is how to test for your subcoracoid impingement. So if there is a pathology of the subscapularis muscle, if there is a subcoracoid bursitis, then this impingement might be positive. It will not be gliding as smooth as what you can see here in the healthy volunteer. So now another important is your subacromial impingement. So normally, if I'm doing the abduction, what happens? You see, this was the greater tubercle where the supraspinatus muscle is getting attached. So this is the greater tubercle where this is attached. And normally the greater tubercle goes below the acromion in a normal healthy individuals. I'm doing the abduction and see this is going below the acromion. The greater tubercle is going completely below the acromion. So that will not happen if there is a subacromial impingement. So this is the one impingement, subcoracoid subacromial impingement. So now let me come to the posterior aspect. So in the posterior aspect, after I'm completing these muscles and tendons, then I'll be going into the ligaments. Some of the ligaments I have already shown, but few more ligaments are there. So supraspinatus, already I have shown him that if I'm going above the spine of the scapula, this was spine of the scapula. If I'm going above the spine of the scapula, this is supraspinatus muscle in the long axis, and this is supraspinatus muscle in the short axis, cardiac axis. Now, if I'm coming below the scapula, so below the spine of the scapula, this was the spine of the scapula. This is the spine of the scapula. I'm coming below the spine of the scapula, and my aspect marker, let me put my aspect marker below on the lateral side. So I'm going lateral side. So this white area is the central tendon of the interspinatus. So here, this is your deltoid, and below that is your interspinatus muscle. This is the central tendon of the interspinatus. If I'm going medially, then this is the central tendon, and this is the muscle part. This is the muscle part, and this is the central tendon part. So if I'm going laterally, it is getting attached here, Bartbeck appearance over the greater tubercle. Greater tubercle, middle facet. Superior facet, I already told you, supraspinatus will be getting attached. Middle facet, where it will be attached, the interspinatus is getting attached. And at this point, what you can see here, this triangular hyperechoic area is your. Let me reduce the depth a little bit. And let me increase again also a little bit, so that you can appreciate this. This is the labrum. This is your head of the humerus. This is your glenoid. And here, this is your spinal glenoid notch. This is your spinal glenoid notch. And here you can see the pulsation of the artery. You can see the pulsation here. You just look at there. I hope you can appreciate the pulsation here. So that artery is and accompanied by the nerve, that is your suprascapular artery and the nerve. So this is the suprascapular artery and the hypericral structure is your nerve. So here, if you are blocking it here, if you are putting the probe here, then you are not going to block the muscular branch of the suprascapular nerve. So this is nowadays done. So this is your glenoid, this is your notch, this is your head of the humerus, this black line is your hyaline cartilage, and this is your the labrum, the fibrocartilage. Fibrocartilage looks white. So now, if I am going here, teres minor, here you will not be able to see, difficult to appreciate. If I am going down when the humerus, this is your teres minor. These muscles become the teres minor. But teres minor identification, there is an easy way to show identify the teres minor. So what is to be done here? So my aspect marker is again towards the humeral head, and you just look at this muscle. This is head, this is sap. Here at this junction, this muscle is the teres minor muscle. And here, this is your posterior humeral circumflex artery accompanied by the nerve. So this is your quadrangular space. So just below just distal to this is teres minor muscle, this is your quadrangular space. And here you can see the hypericral structure. This is your nerve and this is your pulsating artery. So this black dot is your artery. You can see the pulses in there. So this is your artery. Sometimes taking color, sometimes not taking color. You can easily appreciate the pulses there. And just on this proximal side, this is your, and this muscle is your teres minor muscle. So now, after looking at the teres minor muscles, if I am making it in the long axis, this is short axis of the teres minor muscle. So if I am going with the long axis of the teres minor muscle, so this was teres minor muscle. So now what I am doing, I am making it a long axis. Look at this muscle, keep eye on this muscle. Okay, let me rotate on this way so that aspect marker will be. So this was your teres minor, sorry, this was the teres minor. Teres minor. Now I am rotating it. Rotating it. Rotating it. So this is your teres minor muscle. And here is, remember that it comes below the, see here is your head. This is not head, this is the sap. So just below the head, where the teres minor. So this is your teres minor muscle. This muscle is your teres minor muscle. This muscle is your deltoid muscle. This is teres minor muscles. If I am going above, teres minor muscle is finished, completed, and then it is the central tendon of the supraspinal, interspinatus. This is the interspinatus muscles with the central tendon of the interspinatus. And teres minor muscle is here. This is teres minor muscle. And I have shown you the nerve, two nerves. This nerve was in your quadrangular space. This nerve can be blocked here to block the axillary nerve. And to do the radiofrequency ablation, I'll be sending you on the video of the radiofrequency ablation of the shoulder joint, this nerve. So you have to go laterally. So here you can see the artery very nicely pulsating. If you are going more laterally, where the artery will be finished, just it will be, that is the area where the teres minor tendon is just becoming fully tendinous. So, and your cortex is just completed and you cannot see the artery anymore. So that is the time where you should be stimulating. I'm just reducing the depth so that you can appreciate it better. So now you can see at the center of my screen is your teres minor and the artery pulsating. So now if I'm going laterally, teres minor will be becoming fully tendinous and artery circumflex posterior humerus artery will be gradually vanishing. At this point, you should target here. Your needle should be coming like that and injecting doing your radiofrequency or the current anesthetic or dextrose injection there. Okay. So now so two target, if you wish to denervate, two target I show you. One is your spinal glenoid notch, another is the quadrangular space. The another important area is your, again, my aspect marker is towards the medial side. And here, over the coracoid, this is the coracoid, and over the coracoid, here, you should be placing the needle and you should be doing it. So the coracoid, as I was telling you, the few tendons are there. Here you can see there are two tendons. One is your long head, short head of the biceps, another is your coracobrachialis. So this side is your short head of the coracoid, and this is your coracobrachialis. And if I'm going laterally, medially, sorry. So this is the tendon of the pectoralis minor. So all these are getting attached with the coracoid. So now, 2-3 ligaments are important from the coracoid process. One is your coracohumeral ligament. This is the coracohumeral ligament already have shown you. But if I am look at my probe position, I am keeping the aspect marker probe towards the proximal side of the probe over the coracoid, and I'm rotating it towards the acromion. So now the bone, what is coming here is your acromion. So this ligament is your coracoacromial ligament. So one side of my probe, this is a very thick ligament. So normally it's approximately 3 millimeter in wide. So this is your coracoacromial ligament. Why the coracoacromial ligament is important? Because coracoacromial ligament is making a tunnel through which the supraspinatus muscle is coming. Look at my probe position. And if I'm coming distally, I'll be able to see this is your supraspinatus. This is for supraspinatus in the short axis. So this is supraspinatus in the short axis. If I'm going, so now this is your coracoacromial ligament. So this ligament, so this is your coracoid, this is your acromion, and this ligament is your coracoacromial ligament. So now, again, the thickness of this coracoacromial ligament can cause the impingement, because you can see this is the bicep supraspinatus tendon. So this supraspinatus tendon can be impinged if that is thick. So this is your coracoacromial ligament. And now, very nicely seen, this is your coracoacromial ligament. This one. And now, if I'm going more, rotating, keeping this side of the probe over the acromion, and I'm rotating this side probe, now another bone will be coming. That is your this is clavicular. So this ligament is your coracoclavicular ligament. So this is your coracoclavicular ligament. Lateral part of the coracoclavicular ligament is known as the trapezoid. And so this is your clavicle, this is the bone, this is clavicle, this is coracoid. So this is your coracoclavicular ligament. And trapezoid part. And if I'm going more, rotating the probe, you see how I'm rotating the probe more medially, this is the conoid part of this ligament. And here one of the blood vessels are there, and at this area, the articular branch of the lateral pectoral nerve comes, accompanying these blood vessels. So that is another target for the anterior shoulder pain, which is this lateral, the pectoral nerve articular branches. So they are going here and just superficial to that of the coracoclavicular ligament to go to supply the anterior superior part of the joint capsule. So ablation of that particular branch is important for denervating this lateral pectoral nerve for the anterior superior joint and the superior part of the shoulder. So these are have I left anything? So these are the things. If you wish to have something, if you wish me to repeat something, you can ask me. Okay, intra-articular joint injection. As I told you, anteriorly you can go. And if you wish to go posterior approach, intra-articular joint. So let me increase the depth. Let me show that, because that is one of the commonest, the shoulder joint injection. So you can see this was the labrum. This white line is the joint capsule. This black line is the hyaline cartilage. This is your humeral head. This white line is the glenoid, and this is your spinal glenoid notch. You can see the pulsation of the supraspinatus artery there. The suprascapular, suprascapular nerve and artery. Okay. So now, if you wish to go inject inside, you can come here and inject here in the medial part of the labrum. So this is the area. If you wish to go inject, so you have to puncture this white line. This white line is the joint capsule. So you have to come here and at this position. That means, let me show you with the. So this is the area what we need.
Okay. Anything you wish me to repeat?
AC joint, sir.
Oh,
Oh,
I
AC
forgot
joint.
to show AC joint. Sorry. Okay, so AC joint is very easy. So you palpate the clavicle, you palpate so my aspect, look back, let me look at aspect marker. So this is your AC joint. Let me reduce the depth. Okay, this side is your clavicle, this side is your acromion, and this is your AC joint. And this ligament, I forgot to show this ligament also. This ligament is your acromioclavicular ligament. Acromioclavicular ligament. And if you wish to inject here, in this here, but injection here is difficult. So normally, if you wish to go for the in-plane injection with this approach is difficult. So what you need to can do is, you just put your probe over the clavicle, palpate the clavicle and put the probe over the clavicle. So this bone is your clavicle bone in short axis. Now come distally. So this is your clavicle. This was your clavicle. I'm putting it in the center of the screen. This is your clavicle. And I'm coming distally. Now the clavicle is ending. And this is your joint. This is your joint. And now the acromion is starting. So now this bone is your acromion. So if I'm keeping it here, where the no bone is seen. So now here I can come injections, in-plane injection here or here, either from anteriorly or posteriorly, you can come and inject here. So this is for the AC joint injection, in-plane injection. So you understood in-plane injection? This is how you can, assess the joint. Another thing, the scarp test what series was telling, ask the patient to go on that side and you see whether there is any subluxation. If there is any subluxation, so normally this part, joint part, and clavicular acromion part will be changing it. So if it is grossly changed, then that indicates as dislocation, subluxation. And otherwise, in osteoarthritis AC joint, it is very common. You'll be seeing the irregular surface. You can see the osteophytes there. Okay, I forgot to mention another important ligament. That is your transverse humeral ligament. I have shown you all other ligament almost. So if this is your, okay, let me freeze here. So you can see this is the bicipital tendon. This was your greater and this is your lesser tubercle. And this ligament, which is connecting from this side to this side, is your let me draw the pen. So this ligament is your transverse humeral ligament. And another thing to remember, if you are drawing a line here and you can depth from here to here, this depth should be less than 3 millimeters. If it is more than 3 millimeters, there will be more chance of the subluxation of the bicipital tendon. And if you are having the bicipital tenosynovitis, or if there is a lot of fluid collection inside the effusion of the glenohumeral joint, because the synovial, the sac projects out into the bicipital groove around the bicipital tendon. So if there is any effusion, normally the black side around the bicipital tendon, what you can see here, so this fluid will be increasing in amount. So this white line from here to here is your transverse humerus ligament. Okay. So anybody having any questions?
And the branch, sir, ascending circumflex humeral artery also.
Okay, so I forgot to mention another thing. So that time also I'll be showing the circumflex humeral artery. So that is as I told you, that the coracohumeral ligament thickness measurement can be misleading. Many papers says many things, but here there is more nowadays to see the thickness of the inferior the glenohumeral ligament. As I told you, there are 3 glenohumeral ligaments: superior, middle, and inferior. So the inferior glenohumeral ligament thickness measurement is basically, if it is more than 2 millimeters, then that goes more in favor of that. So how to do that? It is better to have the supine position. So let me put a lot of gel there.
look at the position of the you know it will be ঘুরে বসে so that they can see it. After you like so just posterior to the posterior axillary fold. So this is your humerus. I'm going more medially. This is your humerus circumference artery, just over my these things, pulsating very nicely. Now I'm going more medially, more medially, more medially. Suspect can come and see it when I'll be telling it. So this is the head, and here you can see the, just a minute. Just a minute, when I'll be telling you just. So this is the head, and here. So this is the head, is it? Okay, so this is your, this ligament is your, this white hyperechoic area, this is your, the inferior, the glenohumeral ligament. So this thickness normally is your less than 2 millimeter. If that is, this is your humeral head, this is your sap. So here, measuring of the thickness, that also gives some clue that whether the patient is having the adhesive capsulitis or not. And you can see the circumflex artery as well. Okay, thank you very much. If anybody have any question, you can ask me, or if you wish me to repeat some of the structures, whatever I have shown, I can repeat it again.
Sir,
Yes.
so in case of frozen shoulder, patient is diabetic female, what would be the probable, the best injection to be
The
given?
best procedure to be
maximum-
done is your hydrodilatation. You inject around 20 to 30 cc of the dextrose or normal saline injection within the joint capsule. So how to go inside the joint, I have shown you. There are two approaches. You can come from anteriorly through the rotator cuff interval on the side of the bicipital tendon, or you can come from posteriorly, just lateral to the labrum, piercing the capsule, and you can inject there. Both of them are accepted technique. And you inject a large volume, so that will be distending the joint, and it is basically equivalent to that of the manipulation under the general anesthesia. So that is the technique. And along with that, as I was telling, you can, if the coracohumeral ligament or the superior glenohumeral ligament, they are thickened, you can puncture that, penetrate that also. But the single most important technique ought to be done in the adhesive capsulitis is distend the joint capsule with some volume of around 20-30 cc of the normal saline or the dextrose injection.
Sir, if the patient is in severe pain and crying with pain, so first we have to relieve the pain. So what can we do hydrodilatation during that time? Initial 3 months.
Initial 3 months, normally the if the patient's pain is too much, then intra-articular steroid is that gives the best result. But if the patient is having more of the restricted movement rather than pain comes only when there is a movement, then hydrodilatation is the choice. But in the initial first few months phase, when the pain is too much, so that time intra-articular steroid in the glenohumeral joint is the best choice.
Okay, sir. Thank you, sir.
So do you have to supplement?
Intra-articular steroid injection normally
normally what happens, the pain reduces, but normally the movement do not reduces. But in that situation, what you have to do, you have to give the steroid, and along with that, you do the vigorous exercise program so that also be recovered. That is one way to do that. But if you are encountering the patient in the later stage, when the pain only with the movement, no rest pain, that time you can go ahead with that. Okay, Siris was telling something. Siris.
Do we need to block suprascapular articular glands
That is another
before
option. If you normally, if you are doing the manipulation, then you can think of doing the suprascapular nerve block. But nowadays, as I was telling you, temporary block during the manipulation and the GA, we can do that. But otherwise, suprascapular nerve block at the suprascapular notch is obsolete nowadays. So if you wish to block, suppose recurrent severe the adhesive capsulitis. Basically, if you are dividing the shoulder pathology, what Shiris already told, just for the quick recapitulation, for the shoulder pain can be intrinsic, extrinsic. Intrinsic atraumatic causes can be glenohumeral, extraglenohumeral. Glenohumeral causes are adhesive capsulitis and the osteoarthritis of the glenohumeral joint. In both this situation, if the patient's pain is recurrent, not relieved, long-standing, then you can go ahead with the nerve block. Nerve block means depending on which side is pain. If it is posterior, then your suprascapular nerve. If it is anterior, then is the lateral pectoral nerve. If it is lateral, then it is axillary nerve. So you can block those nerves, either temporary or chronic cases. You can go ahead with the radiofrequency or the cryoablation of these nerves. But for the ease of the manipulation or for the ease of the dilatation, to reduce the pain of the dilatation, you can go ahead with the suprascapular nerve block as a pain relieving technique that you can do under only the local anesthetic. Any other questions from anybody? No more questions? Okay, then I'm stopping. Thank you very much. And you can go ahead with the recordings. And if you have any questions, next day you can ask. Meanwhile, I'll be sharing with the Kahoot questions. You go to the Kahoot questions, which will be available for 1.5 days. So thank you very much for joining. And please go through the recordings. And if you have any questions, please don't hesitate to ask us.
Thank you, sir.
Thank you, sir.